I really come from Finland, the northern part of Finland, actually. I am a pediatrician, and I'm doing my PhD on pediatric ventilation, and NAVA plays a major role in our studies. Today, I will present you the results of my first publication in terms of asynchrony in infants. I want to thank the organizing committee for this opportunity. In my presentation today, I will start with explaining why we decided to compare the different trigger modes. Secondly, I will present shortly the study design and patient population, after which I will demonstrate you how we defined and measured asynchrony, and following the results, a short discussion on asynchrony in infants. This study was published in Pediatric Pulmonology. When we first started using NAVA in December 2008, we were very astonished by the amount of asynchrony present in all our patients with the routinely used ventilation modes and trigger levels. With NAVA and EDI signal, it became clear that what we previously had seen on the ventilator screen as a small sign indicating patient triggering did not actually at all, or at least not much, correlate to how the patient was trying to breathe. We also realized the essential role of correct trigger level to the synchrony, and this led us to plan a study in which we compared the routinely used ventilation modes and trigger levels, flow trigger +5 and pressure trigger -2 to NAVA. From February to May 2009, we recruited patients from our pediatric and neonatal intensive care units to this randomized crossover study. All patients from 30 weeks of post-conceptional age up to 16 years in a weaning phase of invasive ventilation were eligible. The ventilation modes used for these patients during the study were pressure-controlled ventilation for children under 3 months of age and pressure-regulated volume-controlled for older ones, as it still is in our hospital in many cases. The sample size 15 was calculated based on the previous publication by Beck et al. 2004. By that time, we had only one ventilator with NAVA program, and thus 3 eligible patients were not randomized due to a lack of available NAVA ventilator. The patients were randomly allocated in the 6 groups according to the order of trigger modes used, and 10 minutes of each trigger mode were recorded. The patient population of our pediatric intensive care unit became very well represented in our study with a large variation in age and size. Only 2 of these patients were recruited from the neonatal intensive care units, and those were the premature ones, numbers 8 and 15. I have circled here patient number 6, a 10-month-old boy with bilateral pneumonia. I will use the data recorded from this ventilation episode later in this presentation as an example of our measurements. But first, let's see how we defined synchrony and asynchrony. We wanted to approach this from patient point of view, and with this new tool of EDI, we defined the synchrony as simultaneous inspiration by the patient and ventilator, seen as an increase in EDI, and increasing or high pressure given by the ventilator. Similarly, expiration was in synchrony when EDI decrease was simultaneous with decreasing or low pressure by the ventilator. On the other hand, asynchrony was present when the directions of these parameters were opposed. The data was collected straight from the servo eye with NAVA tracker and converted into a visual form by using graphical user interface running in MATLAB. Dr. Tuomo Ylinen from Finland made this program for us particularly for this study. The total time registered was also analyzed, and no washout periods were used in between, because we could not think of any mode of invasive ventilation which would not have effect on patient's breathing pattern. Here you can see how in our program the EDI flow and pressure curves were illustrated in one picture frame. The time running in the x-axis in seconds, and the vertical lines demonstrating the ventilator data on breath cycles. The asynchrony was marked with red arrowheads joined with red lines. And the program calculated the total time in asynchrony and its proportion out of total length of the signal. You see the patient number 6 with pressure-regulated volume-controlled ventilation with flow trigger and with pressure trigger. And as you can see, the wasted efforts are seen in both pneumatic triggers, in this case mainly due to improper inspiratory time used in this PRVC. In NAVA, the asynchrony in this patient was only caused by the preset level of the cycle off. As we know, the EDI needs to decrease to 70% of its highest peak before expiration starts. We found out that approximately 1/3 of the total time in ventilation on ventilator, the child and ventilator were in asynchrony when the routinely used controlled ventilation with pneumatic trigger was used. In NAVA, the proportion of time in asynchrony was 8.8%. This difference remained significant even when the low EDI time was interpreted as synchrony. As you can see, there were patients who had even over half of the time ventilated in asynchrony. In addition, we found out that the peak inspiratory pressures were lower and respiratory rate was higher in NAVA than in conventional ventilation. If some of you have wondered the high levels of EDI max values reported, I must clarify that these are the highest peaks of EDI measured during the recordings and do not indicate the mean value of it. It is clear that precise sensing of spontaneous breaths remains in an essential role for synchrony, and especially when we want to aim at avoiding wasted efforts, false triggering, and double triggering. The ventilation modes has huge effect on the time in asynchrony, and the ventilation modes that enable changes in inspiratory time are the ones improving the synchrony most. In our study, the asynchrony in NAVA was mainly caused by this preset level of breath termination. But as Jennifer today in the morning argued that actually this is not asynchrony at all. It's a quite interesting point of view. And then I think it raises the question whether the 70% threshold is the right one for all infants, or should we have adjustable cycle off also in NAVA. As a conclusion, I'd say NAVA significantly improves the short-term patient ventilator synchrony in infants, but whether it will lead to any improvement in survival, length of stay in pediatric ICU, or time on ventilator remains to be seen. Thank you.